Good morning, everybody. This is Dr. Sujata Sharma, and on the behalf of Biofootprints, which is an organization which aims to promote science in the society, I welcome you all to this Marie Curie Award lecture series. And our awardee is Dr. Parul Kodan, who's an assistant professor in the Department of Medicine, AIIMS. And let me introduce Dr. Parul now. She has also done DM from the same department in AIIMS. Her field of specialization is infectious diseases in medicine. She's a young doctor with passion to do impactful work in infectious diseases, especially neglected tropical diseases, HIV, tuberculosis, and antimicrobial resistance. So just now we have been through a COVID pandemic. It has not got over yet. Still, I think the people, the young doctors who were out on the forefront were the ones who were extremely courageous and they showed exemplary spirit while dealing with this pandemic, and Parul was one of them. During the COVID pandemic, she worked full-time in the COVID ICU and wards. She also took this opportunity to be a part of several randomized controlled trials and studies to unfold the mysteries of this virus. Some of the notable studies that were done by Parul were on plasma therapy, COVID in immunosuppressed population, study on breakthrough infections in covaxin vaccinated individuals. This study was published in Lancet Infectious Diseases. It was a landmark study, and case control study on COVID associated mucormycosis, amongst others. She is presently involved in several projects, including the role of CARBA R in tackling gram-negative sepsis, role of PET in EPTB diagnosis, and follow-up of post-COVID sequelae. She wishes to continue that pursuit to identify important clinical problems and try scientific solutions to make her contributions in the ocean of science, as she says. So welcome, Dr. Parul, and without wasting any more time, over to you. Thank you.
So I'll take you down a journey of what infectious disease has been to me. So infectious disease has been a branch which has been just so very neglected. And when we talk about it, forget about the general public in general, even medicals, even educated, even scientists, they do not really give enough glamour and concern to this branch as what I have seen all this through. So what is infectious diseases in Indian perspective? I'm sorry for the delay, I'll just share it up here. I'm sorry for the technical issues. Starting with infectious diseases in India. India is unfortunately one of the largest burden of AMR superbugs. It is a country lurking with one of the most deadly and dangerous resistant organisms. It is unfortunately a country which bears the highest burden of TB cases in the world, with more than 1.5 million cases of malaria every year. 1/3 of filarial cases of the world resides in India. There are more than 300 million episodes of diarrhea in India in children less than 5 years. And the list goes on endlessly. And this is the official figure. If we actually talk about the actual numbers, India is the single largest, infectious disease in India is the single largest cause of death. Yet, it remains neglected and we do not talk about it. Talking about emerging and re-emerging infections, it is very unique in India because each part would have a very different organism with a different clinical presentation, and a lot of them remains undiagnosed if not taken care of. And talking about training of infectious disease, 2020, there are less than 25 qualified ID doctors in India. And there's been a lot of talk about urgent need of formal medical training in infectious diseases in India, a formal research laboratory for infectious diseases in India. There's a lot going on around in the tech centers on some of the very well-known infectious diseases like tuberculosis, HIV, but still a lot of them remains unknown and uncharted. What basically is infectious diseases? It's a branch of clinical and laboratory synergy, where we talk about infectious diseases, travels, vaccination, providing an outpatient service. It involves consultations for difficult to treat infections. It involves ward and ICU care for infections which are difficult to treat, including sepsis. Obviously, COVID care is a part of the spectrum. It's a branch which stresses on the infection control practices and how to save the progression of diseases and how to prevent the development of antibiotic resistant bugs. It talks about TB, HIV, fever, pyrexia of unknown infections, and definitely a lot of neglected infectious diseases, including mycology, parasitology, a lot of which we do not even count in our list. Seeing the brief overview of infections, it's a big basket of bacteria, viruses, fungus, parasites, and the list continues. Research in infection as of now hardly includes thesis, or compulsory research methodologies, or short internships. But there's definitely a need to more. I have learned a lot while doing my thesis and having the research methodology and internship. But still, there were a lot of things which we still face and which I faced during my training. Where is the bug? Where exactly is it? If the patient is coming from some part of the country, what can possibly be there? A lot of this is still uncharted. What is the best antibiotic of choice? What should I do when none of the antibiotic is working? How to diagnose a case? How to follow up a case? What are the rarer cases and how to approach them? COVID has been a very perplexing virus with a big Pandora box. And vaccines, do they help us? What are the trials? And post trials, what is the actual efficacy we see in the real world? So that's what we've been trying to see and solve the problems. It has been a teamwork, a team effort. I have worked under my faculties, worked with my residents, worked with my friends and colleagues, and together we have done some work to try and look for this. Starting with case reports and case series. In the ladder of publications, letters and case reports have very little significance. But they're the ones which had helped me document important findings. They're the ones which had which have added to the literature of something which has been very few in this world, hardly ever documented. It has been a way to review the literature and document the scientific findings and help me learn from them. So there have been several cases, very challenging cases, trying to find out important areas and getting introduced to the diseases. And more from the cases, we moved on to bigger studies where we had more common cases which we see every day. But there was nothing compiled with that. So we tried to collaborate and put it together our experience. Like one of that is for the dengue, in which we did it for 1 year and then later for over a decade, about all the confirmed dengue patients admitted in our department. And we looked at the case fatality rate and the different parameters. And what we found is what has been always associated as platelets is equal to dengue. But that is not the case. Platelets is just one aspect, and platelet count may not be directly related to the outcomes in most cases. So just analyzing the data helped us give us a lot of information. Well, all that data had already been there. It was just an effort to compile, collaborate, and learn from that. Moving on from the institutional setup, under the guidance of my faculty, we moved on to something bigger. We've had a big Zika outbreak in 2018, but to report it, we did map it out. We tried to put it the year-wise, the number of cases, and how this outbreak was very different from the future from the previous outbreaks, and how we can evolve and get prepared for the future outbreaks. But in all these things, we still have a lot of the infections which are not talked about. We're having the diagnostic challenge. We have a strongyloides infection, which is well talked about in all the books. But there's hardly a test which is available to get it tested. And that's when we started a small pilot project of looking for prevalence of strongyloides in the patients who are immunocompromised. And we found significant number of patients do have it. And that's what made us more careful while prescribing and screening for the treatment of strongyloides in patients who are on steroids and patients who are who are post-transplant. So we're trying to figure out challenges in diagnosis and learn from them, learn about co-infections, learn about when different infections coexist together in a setup which is a high tropical setup with high burden of several infections like India. We have tried to do some work on the drug resistance of tuberculosis, case reports and case series of what we talk about extrapulmonary tuberculosis, but still till date, we do not know what is the exact date to stop the follow-up and how to go about it. And when the traditional methods change, do something like PET in selected cases help us to know about the functional outcome of these patients. We've tried to document the role of various therapeutic drugs in the rarer cases we have we have done. Well, all this journey is continuous and the number of problems are innumerous, and we are just a very small drop in the world we are in the field we are working, we were stuck by the COVID pandemic. And as all other friends and all other doctors, we did went into the COVID wards and ICUs working to take care and heal the patients. But at the same time, we did not really know what we were doing. We were trying hit and errors. We did not know what was the best medicine. We did not know what we need to do. And that's when it was very important to use science and to find solutions. And that is where we went wrong several times. A lot of drugs we did try did not work out. HCQ was one of the initial drugs we had thought would have some things, but our trials did not show the benefit we would have liked to see. We're talking about plasma. We did a randomized control trial, multi-center trial in collaboration with ICMR, where several centers across the country saw the benefit of plasma, patients with and without plasma. And the trial did not show any benefit and was published in BMG. However, this is not the end of the answer. We are still looking for further solutions. We're still looking, maybe a subset of it would have benefited, maybe the plasma we had used had not done. And so a lot of research questions still goes unanswered, and we're trying to collaborate at different stages. My friend in West Bengal has been doing a study on a very subset of patients with a very high enriched plasma and have been seeing various results. So yes, we got an answer from this, but the answer is not the deadline, and that's what science is about: questioning and then re-questioning what the results are and trying to evolve and evolve our clinical practices along with that. We did a lot of clinical profiling of patients who are severely in critical ICUs, patients with malignancy, trying to explore COVID-associated mucormycosis. And all this line, there were several challenges. There were certain trials which we worked really hard. There was a randomized control trial about mucormycosis and treatment. Me and my friend had written the protocols, and we had been very, very ambitious about the trial, but somehow it never saw the light of the day. We did not find the drug initially, the ethical approval came, and by the time the wave had subsided, and we could not really do much about it. But then we learned from the entire process, and we have been trying to see what we can improve in future. Now, one of the study which ma'am was talking about is about vaccines. Just when we were talking about COVID, something which was a light of hope at the end of the tunnel was vaccine. And that was something which was very exciting for us also. And we really wanted to see how it did. And we did around 3 studies. I was a part of 3 studies in our department, which are trying to explore it. While the other 2 studies are still under publication, one of that has been accepted by Lancet. This is a study which shows the effectiveness of inactivated virus-based SARS-CoV-2 vaccine, that is the covaxin vaccine in particular, with a case control design, where with a test negative case control design, where we took around 3,000 study participants. All these patients were employees of AIIMS and the extended family with employment EHS beneficiaries, and we tested them from COVID. So we took a group who were tested positive and the other group who were not tested positive, and looked in the vaccine dosage of them. While this is out in public domain and now a lot of studies are there on that, what we did at that time was one of the very initial times when we had no idea about the vaccines and about how they're actually performing in this. So this was one of the first real world observational study where we found the vaccine effectiveness to be 50%. While how we interpret it and how it would be for severe COVID and critically care COVID, we need much more data size, and we are still working and following that study up, and we are still in the process of doing it. But this shows us an evidence about something which was positive and something that we need to go along with the pharmacological measures, with the non-pharmacological measures, and take our precautions while we are tackling COVID. While we are still exploring this perplexing virus, I have learned from collaborations with different people, with different societies, and have been fortunate that European Society of Infectious Disease have acknowledged this and given for the first time the Outstanding Training Award to somebody who is outside Europe, who is from Asia. And all this thanks goes to my department, my colleagues, my friends, because we've all done together as a team and have been trying to evolve. Well, I'm still struggling. I'm struggling for a regular job, struggling between job, family life and professional life, struggling how to manage clinics and research together. But it's a team which helps. It's a department of medicine. It's a department of Institute of AIIMS. It's all my friends in the institute and outside the institutes who have helped me grow and learn from the process. My family has always been there. And talking about the future, I hope infectious disease is recognized as a branch to work specifically on the clinics and research of it, to promote the rational practice of infectious disease about antibiotic stewardship so that we can reduce the resistant pathogens and develop a state-of-art facilities to teach, diagnose, manage infections. But all that cannot happen unless we have multidisciplinary cooperation and research collaborations. So while we look forward for this exciting journey ahead, I think what is most important for me have been to work as a team, because when we, instead of competing, if we collaborate and coordinate, we are better able to find solutions. So let's learn from each other, from our seniors, from our colleagues, from our juniors, and together find a solution. And any addition we do to the world of science would possibly leave a footprint behind, as the Society of Biofootprints also gives us the message. And I hope that we can continue this journey of infectious diseases and sciences with guidance and collaboration with everybody.
Thank you so much, Parul. That was a very powerful address. It simply took my breath away, the way you started and the way you have been in the wards. And at the same time, you've been able to do such, I mean, it's excellent, just brilliant research that you've been able to do. And I love your positivity, optimism through it all. And if anybody has any questions, they can ask. I have a couple of them, but maybe others can ask first. Jia Singh has written in the chat box, Parul, what is the one important factor responsible for antibiotic resistance?
It's just not one factor, there have been many factors across the line. First and the foremost is recognizing its importance. It starts from infection. Infection prevention practices have been something which definitely needs a lot of work. We are also doing a lot of pilot projects in our department. We have done it as a part of pilot projects where we try to strengthen that behavior, and we have to reinforce that infection prevention practices every single day and every single moment so that we do not develop infection. Then moving on to why resistant infections, if you ask me one single factor, I think that has been the practice of prescribing antibiotics irrationally. That is something which needs to come to a stop. We need to realize antibiotics are not the answer for everything. It is so disheartening to see a patient who comes with viral infection, who possibly does not need any medicine at all, will be on a list of 9 to 10 antibiotics. Many of them have been popped by himself or herself from pharmacological, from his friends and advice of people who probably benefited from it without even understanding the course. So if I have to give one message to the group, I would be to use the antibiotics very rationally, to use them when they are required, to use them in right dosage, right time, in right way. And that's what can help us prevent the antibiotic resistance further.
Akshita says, very informative talk. Pradeep has asked this question, Parul. What is your say on natural proteins? I think natural antibacterial or antimicrobial proteins, which can be used as protein antibiotics.
Well, we are definitely running out of antibiotics as of now, and we need solutions for that. I do not have a data or an experience in using protein antibiotics, but all methods, whether it be the microbiota, whether it is proteins, we definitely need to explore, do our research and find answers to these very exciting options so that we can overcome the crisis of antibiotic resistance. So I look forward for more work and for finding solutions of natural proteins to look for answers for solving the problem of AMR.
Okay. Sonika wants to ask something. Sonika, please go ahead.
Dr. Parul, first of all, congratulations for winning the award and wonderful talk, let me say. It was so insightful hearing from you about your approach, your multidisciplinarity, and so much enthusiasm for research. It's really nice to see. I wanted to ask, what's your experience with long COVID?
Experience with long COVID, yes. We've been trying to make our own cohort of post-COVID patients also, and we're still following it up. So one of the studies which has been published has been in 1,000 patients post-COVID, but all these patients have been in the first wave. And what we have seen is it's very different in the first wave and the second wave, and probably what we call the Omicron, the third wave. So the virus has acted differently. There have been patients on long COVID. Each one of them have had unique problems, fatigue and fatigue being most common. One of the findings we've seen, the patients who had more severe COVID are the ones who have had a little more complications in the long COVID. A lot of them completely resolved. A lot of them are still under our follow. So there's no definite answer which I can give you, but yes, we are creating our cohorts and trying to find solutions. While none of them have been really alarming in the third wave, the second wave cohort has been something which has been the Delta variant, in which we did see some cardiac complications, and we are trying to analyze it furthermore.
I'm loving the way, Parul, you are fielding all the questions and giving such brilliant answers. So Anamika has asked one question, that during COVID-19, has the antimicrobial resistance crisis become worse?
Yes, I think. It has been very unfortunate, but yes, it has been multitude. When we wear PPE, somehow the practice of infection control did take a backseat, which has been multifactorial. I won't blame anybody, but then it has been the general tendency that we are gloved, but then that glove has to be changed every time. And the initial part, we were so deeply involved in trying to just adjust to that environment that the other things did take a backseat. So infection prevention being one part. Secondly, the desperate measures to improve. The patients not improving were put on 10, 20 antibiotics, which somehow does not help the patient. But that desperation to just try something had made it not a good scenario. So I think we now need to be all the more careful about AMR and take it forward and talk about it much more than even pre-COVID areas, because that's one of the biggest problems, not just India, but the entire world it's lurking the entire world.
And also, I think because of lockdowns, patients have not been able to reach across to their doctors, and they have been self-medicating. That is also one problem, right?
Yes, that has been a very, very major part. The patients have not been, like when we talk about tuberculosis also, we're seeing a lot of drug-resistant TB cases because they ignored their symptoms. They were chemophiles, they did not visit the doctors on time, the supplies were somehow interrupted. So the entire process has actually taken a big toll on the entire health system.
Exactly. Okay, and Gia has asked you this question: is gram-negative sepsis worse than gram-positive? I mean, sepsis caused by the gram-positive bacteria.
Unfortunately, the antibiotics, the drugs, the bugs which are so resistant now is making the sepsis so bad. So we see a report and it says that RRR resistant in all the organisms, and it is so disheartening, and we try to use salvage options and everything. So this is something we really, really need to work on and try to find solutions. And yes, it is very bad.
Absolutely. So I have one final question, Parul. As a clinician in India, especially if you're working in a government setup, you have so many patients to take care of, and it's mentally, physically extremely exhausting. So it is commendable to see somebody who is working in the setup and is still able to do exemplary research, which is getting published in the best possible journals. So, because I talk to many clinicians and they say we are so exhausted. Just like many basic researchers say, we are so exhausted of teaching that we don't find time for research. And many clinicians say we are so exhausted with patient care that we don't find time and energy for research. So what would be your advice? Pradeep, can you? Okay, yeah. So Parul, what would you say, what would be your advice to clinicians who want to pursue research?
I would say if you just document what you're doing, that itself will be a part of a lot of research. And I have seen that being a part of research helps you being a better clinician because you know you have documented, you review the literature, and then you look back at the problem and the perspective it gives sometimes is very different. So sometimes when I'm just writing a case report, which may not have much importance in the ladder of publication, as they say, but just reviewing the literature, seeing what has happened around the world, and putting things in perspective gives me a new shift to it. I mean, a new vision to it, and that has helped me treat the patient. So what I feel is there's nothing big and small. We need to just document what our scientific findings are. We need to document our patients' findings and keep them as a record. That itself is a major beginning of the research. And along with time, if we do that, we ourselves find solutions. We'll find what are the important problems and look forward to the solutions. And for this, I would say I'm really fortunate to have very enthusiastic batchmates and juniors and seniors and faculties who've been guiding ever since for everything. So, and it has helped. I mean, I think all my colleagues would have worked harder than this to try and find solutions, and that's inspiring and and it's rewarding at the end. And at the end of it, juggling everything, when you sit back and you see that it has made an impact and it has improved the life of a patient, that's what makes your day. And takes all the energies and difficulties you had actually seen.
Absolutely. So there's one question Sanjeet has asked. What are the general standards for rational use of antibiotics?
General standards for rational use of antibiotics would be to use antibiotics first when it is required.
Only then, yeah.
When and at what dose and what prescription it has to be. So it will depend upon the antibiotic, what is the course, whether it has to be a 5 days course or a 14 days course, depending upon what infection you have and what dose and duration. And if a particular dose and a duration has been prescribed, to follow to that and be adherent to that, rather than just skip it and change it and not follow the prescription.
Okay, Parul, I think we should probably end this wonderful session here. And I always feel that the way you can judge how your session went is through the question answer session. If your talk has incited a lot of questions in people's minds and you've given wonderful answers, which makes people ask you more questions, then your talk is extremely successful, as we can see over here. And I think this is the best half an hour that I've spent in the last few days. And thank you so much, Parul, for this.
Thank you so much, ma'am. Thank you so much for this opportunity.
And we are going to have some more sessions in which we will probably not just have a lecture, but maybe we can talk about women in science and how they balance, because that's a very big question nowadays. So we can have some kind of panel discussions on various topics like antibiotic resistance and things like that. And I would look forward to inviting you again, Parul. Thank you so much.
Thank you.
Thank you, everyone.